Inappropriate antidiuretic hormone secretion, or SIADH. This disorder is characterized by impaired water excretion by the kidney due to excessive secretion of antidiuretic hormone. Antidiuretic hormone, also known as vasopressin, is normally produced in the hypothalamus and secreted from the posterior pituitary in response to a rise in plasma osmolality or a decrease in intravascular volume. High circulating antidiuretic hormone levels stimulate V2 receptors in the renal collecting ducts and late distal tubule segments, leading to increased expression of aquaporin channels that facilitate water reabsorption by the kidney. This results in production of concentrated urine, with the reabsorbed water helping to lower serum osmolality and increase intravascular volume. In SIADH, there is excessive secretion of antidiuretic hormone that is not responsive to changes in plasma osmolality or intravascular volume status. Excess water retention by the kidneys leads to an increase in total body water that dilutes the serum sodium, resulting in hyponatremia. The excess water also initially causes a mild increase in extracellular fluid volume, which causes suppression of the renin-angiotensin-aldosterone system, along with increased production of natriuretic peptides. This leads to increased excretion of sodium in the urine, which helps normalize the extracellular volume but also further compounds the hyponatremia. As a result, patients with SIADH have a clinically normal volume status with a low plasma sodium level, a combination which is termed euvolemic hyponatremia. SIADH can occur due to a variety of underlying conditions. Virtually any type of CNS disorder can result in enhanced antidiuretic hormone release, including stroke, hemorrhage, infection, and trauma. Malignancy is another frequent cause of SIADH due to ectopic production of antidiuretic hormone. This occurs most often with small cell lung carcinoma. Many drugs are also associated with SIADH, either by increasing antidiuretic hormone release or enhancing its effect on the kidney. Commonly implicated medications include anti-epileptic drugs such as carbamazepine, selective serotonin reuptake inhibitors, NSAIDs, and MDMA. Pulmonary diseases, particularly pneumonia, are another frequent cause, although the mechanism is not well characterized. SIADH is also common following surgical procedures, as pain and nausea can induce excessive antidiuretic hormone secretion. The clinical manifestations of SIADH develop due to hyponatremia. Although many patients appear relatively asymptomatic, symptoms usually become more prominent with larger and more acute drops in the serum sodium. Mild symptoms are nonspecific and include nausea, vomiting, headache, confusion, lethargy, muscle cramps, and gait disturbances. In severe cases, life-threatening neurologic manifestations such as seizures, coma, and brainstem herniation can develop due to cerebral edema. Characteristic laboratory features of SIADH include hyponatremia and serum hypoosmolality that result from excess free water in the body. In addition, the urine is inappropriately concentrated relative to the low serum osmolality, which reflects the inability of the kidneys to produce dilute urine. SIADH should be suspected in patients having a combination of hyponatremia, low serum osmolality, and an inappropriately high urine osmolality. Confirmation of the diagnosis involves ruling out other causes of hyponatremia. Normal extracellular fluid volume is a key feature that distinguishes SIADH from other causes of hyponatremia, such as vomiting or diarrhea, which induce a hypovolemic state, and heart failure or cirrhosis, which induce a hypervolemic state. Ensuring that patients are euvolemic is a necessary part of the diagnosis of SIADH. Therefore, patients should be assessed for clinical features of volume overload, such as peripheral edema, pulmonary crackles, and elevated jugular venous pressure. Patients also need to be assessed for volume depletion. Normal skin turgor and absence of dry mucous membranes can help exclude hypovolemia, but mild volume depletion is often difficult to determine based on examination alone. For this reason, measurement of the urine sodium concentration is used during the workup of SIADH. A high urine sodium helps confirm a euvolemic state, as urine sodium is usually low in the setting of true volume depletion. Once euvolemia is established, other potential causes of euvolemic hyponatremia need to be ruled out. A high urine osmolality differentiates SIADH from primary polydipsia, where urine osmolality is low due to massive water ingestion, as well as malnutrition, in which urine dilution is maximal, but the very low dietary solute intake limits the total amount of water that can be excreted by the kidney. After making the diagnosis, the cause of SIADH may be obvious based on clinical history, as in a patient recently started on an SSRI. In other cases, further evaluation may be needed to identify the cause, such as performing imaging studies to assess for underlying malignancy, pulmonary disease, or CNS pathology. Management of SIADH focuses on raising serum sodium levels to a safe range while minimizing the risk of complications. Several treatment options are available for correcting the hyponatremia. Fluid restriction is a cornerstone of treatment for most patients with SIADH. The limited water intake results in a negative water balance as urine continues to be produced, which increases serum sodium levels toward normal. Another common component of therapy is increasing solute intake, such as with oral salt tablets or hypertonic sodium chloride infusion. The high solute load replenishes serum sodium and also helps increase total urine output. Vasopressin receptor antagonists, or VAPTins, are another potential treatment option. These agents block the action of antidiuretic hormone on the renal collecting ducts, promoting a selective water diuresis that increases serum sodium levels. The optimal rate of correction of the serum sodium depends on the degree of hyponatremia as well as the severity of symptoms. Patients with profound hyponatremia or severe neurologic symptoms require rapid initial correction in order to prevent lasting morbidity or death. However, overly rapid correction of chronic hyponatremia can precipitate osmotic demyelination syndrome, a severe, often irreversible neurological complication with potentially devastating consequences. As such, serum sodium levels need to be closely monitored in patients undergoing more rapid correction. In addition to raising the serum sodium, treatment should also include management of the underlying factors responsible for SIADH. In some cases, the cause of SIADH may be self-limited, as with nausea or pain due to recent surgery. In other situations, definitive therapy may be necessary. To sum up, here are the key points to remember. SIADH is characterized by excessive secretion of antidiuretic hormone that is not responsive to changes in plasma osmolality or intravascular volume status. High levels of antidiuretic hormone lead to increased aquaporin expression in distal segments of the nephron, facilitating water reabsorption by the kidney. The resulting impairment in renal free water excretion results in hyponatremia, decreased serum osmolality, and inappropriately high urine osmolality. Patients remain euvolemic due to suppressed production of volume-regulating hormones such as aldosterone and natriuretic peptides. Common causes of SIADH include CNS disorders, malignancy, medications, pulmonary disease, and recent surgery. Clinical manifestations are a result of hyponatremia, which in severe cases can lead to seizures, coma, and brainstem herniation. SIADH should be suspected in any patient with hypotonic hyponatremia and inappropriately concentrated urine. Confirmation of euvolemia is a necessary part of the diagnosis. The mainstays of treatment are fluid restriction and increased solute intake, which help increase serum sodium levels. Vasopressin receptor antagonists are also used in some patients to decrease urine osmolality and facilitate water excretion. Avoidance of overly rapid correction is critical to prevent osmotic demyelination syndrome.